you have been involved in. So for those that may not have heard previously, what is the changes that have occurred in spine surgery that you've been very much instrumental in initiating? Are what I would have described the things that took place in orthopedics probably about 25, 30 years ago, where we went from opening up everything to doing things through minimally invasive surgeries to accomplish the same goals. So you've been at the very forefront of trying to change spine surgery in that fashion. So for the ones who haven't heard the story before, could you maybe give us a summary of what you're trying to accomplish these days?
Well, I guess you just nailed it. You just summarized it beautifully, that the spine is just catching up. And that's not by few years, by decades maybe, that in other areas of the medicine, we go from big opening to small opening, from lots of collateral damage to get the job done to practically going straight with a small hole where the problem is and fixing that. The problem with the spine is that spine doesn't give you any approach. It's in the middle of your body, very strategically located, and there are lots of vital structure around that. I just got a patient today that went to another surgeon. The other surgeon says, yes, you have scoliosis, meaning side bending of the spine. You need this problem solved, but the surgery is just too big for you. It takes too long, too much blood loss. Yet here, right here in Crookston, is exactly that's kind of people we treat, because we don't do a big opening. We use smaller opening with a very highly specialized technology. We go and fix the problem without causing too much collateral damage. In all areas of medicine, including orthopedic, including general surgery, we already are far, far beyond comparing to regular spine surgery. But I think it's just time for the spine to catch up, and we are truly in forefront of it.
So let's take a step back just for a bit and maybe outline the variety of different things that can be dealt with these new micro-invasive techniques for the back. Now, many people have, they come in, they say they threw their back out. Most commonly, when we're looking at that, we're looking at some sort of problem with maybe a disc in the lower back. Now, these discs are these rubbery cushions between the main bones in the spine. So describe that, how that kind of person presents, and what kind of symptoms they have, and how that would normally be managed.
Well, I really like that you describe the symptoms, because patients do not come to us with diagnosis, they come with symptoms. And those symptoms are mostly pain in the back, or pain going down the legs, or even numbness, tingling going down the leg, or even problem with walking. We have a special name for that, we call that claudication, when people cannot really walk the way they used to walk. Or sometimes as well, they cannot coordinate their legs or arms and hands. And that's all based on the nerves that go to those areas are being pushed by something in their spine. I would say most of the time that thing that push on the spine is either the disc, the rubbery thing between the bone, that instead of cushioning the two bone, actually like an old flat tire, it bulges out, pushes on those nerves, cause tremendous amount of pain, but as well practically prevent the nerves to work properly. In those cases, patients, when they come to us, my job is to find out, first of all, what is going on, because lots of different pathology can have the same symptoms. Based on what the problem is and what the symptoms are, then we put a treatment plan together. Many times, the solution is not the surgery. We have tremendous amount of conservative management protocol, and we generally always maximize them. But for certain group of patients, all of those fail. And when they fail, the problem becomes getting where the problem is in the inside of somebody's body and removing the pressure. And that is where we come and we put a tube that is a little thicker than a pencil to remove the pressure, rather than literally cutting them open and cause lots of collateral damage.
So before we get too much into the details of the surgery, I'd still like to kind of outline for the individuals listening here of the types of things that the words that they might have heard. So you used the word claudication. So this show wouldn't be Fennell Medicine Explained if I didn't tell people what claudication was. It's a big medical word. Claudication effectively is the pain that you get in your legs when you typically get up and start walking, and you're at the beginning you're okay, but as time goes on you start to get more and more discomfort. And it's usually it starts out with a pressure in the lower back, but it can be pressure and then pain that occurs in the legs as you're walking. So the further you go, the worse the discomfort gets. And what's kind of classical about it is if you stop and sit down and relax the back and take away the stress, then that pressure and pain will settle down. So claudication pain is certainly one of the symptoms that we look for. As you mentioned, we look for the numbness and tingling. Sometimes it's weakness. So those are the different things that we'll look for. But then when we start to do investigation, there's a variety of things that we find. And we've already mentioned a couple. One was the discs that start to wear out and push onto the nerves. You mentioned about the issue of scoliosis, or the twisted spine. The symbol of orthopedics is the scoliotic spine being straightened out. So a very common thing. We all know about young girls getting checked in school for scoliosis when they go through their teen years. But a lot of people don't know that the spine, as it degenerates as we age, can also start to twist. And then as it twists, it puts added pressure. And probably the other most common thing that takes place in the lower back is arthritis. Now, we think of arthritis for joints, and we don't even necessarily think that the back has joints, but that's absolutely not true. The back has hundreds of little joints that are all interconnected. So arthritis of the lower back certainly can be a major issue. So we've got disc problems, scoliosis, this stenosis, which is another big medical word, where we've got narrowing of the lower back, space where the nerves come out, and then we have the claudication as a consequence of that. So are there any other major medical conditions? We don't need to go into the weird ones like cancers and things like that, but is there any other more common things that take place in the back that we see?
Well, we have specialized name for different kind of pathology, but something that is actually we see often is the spine supposed to move in a certain way, like two bone that are bordered by a disc. They are supposed to bend in certain way. If they don't move the correct way, and instead of bending, they literally slide on top of each other, we have a specialized name for that. We call that spondylolisthesis, or we in our field we call it sometimes just listhesis, and we add to that as well which direction they slip, forward or backward. We call that antero for forward or retro for backward listhesis. These are special situations, and they're not that uncommon. That requires more than some other pathologies, surgical attention. And so if somebody has been told that they have spondylolisthesis, that means that their spine is shifted, and imagine like two blocks of wood that they are not exactly aligned, that one is actually pushed a little forward. Spine is not supposed to be like that.
So we have so if people wanted to imagine what it would look like, you have the little alphabet building blocks that kids have, and when they're 6 years old, they can put them one on top of the other so that they're all fully lined up perfectly. But when they're 2 years old, they kind of put them together so that one's sticking out a little bit compared to the other one, and that's effectively what's happening with the lower back. Is that these lower back vertebrae are shifting one relative to the other, and then that puts added pressure on the nerves that are around them. So that's the big medical word is spondylolisthesis, and as Dr. Abbasi said, either to the front or the back with other big medical words attached to it. So that's another common thing. So we've got about four different varieties of things. So how do people find out which one they've got?
Well, they come to a person like me. They literally they come with symptoms, and that is mostly pain that is in the back, or pain that goes down the leg or arms or hands. And again, my job as a specialist is to find out, first of all, what's going on now, and number two, if that situation can be corrected by body's own resources, like when you have a wound in your hand, your body usually fixes it, but sometimes if you poke in it, it won't heal. And many things we do in our life for our spine is very similar, or in analogy to poking your hand in a wound. Like if you keep bending and twisting, you're just not giving your spine or certain element of the spine the possibility, the opportunity to heal. First thing we do, we put a regimen together, what to do, what not to do, and then we strengthen spine muscle. We build that your own muscle inside of you, make them strong. We work on your posture. We sometimes give you some anti-inflammatory medication. Sometimes we put you in a brace to reduce the bad motion in your spine, but as well to support your spine. On top of that, often as well, we put steroids. Steroid is a hormone your body produces when it's trying to heal. And by us giving it artificially to a specific location, we speed up the healing process in that location. But as well, we initially start treating the pain as well. So these are all the things we do beside finding out what's going on to practically avoid the surgery. And for every surgeon, I think the first duty is to avoid the surgery.
So we try all these other things first to see if we can get the back to respond. With a son who's a chiropractor, there's also I think that as one of the other options. Let's hear what the expert neurosurgeon's opinion is about chiropractic treatment. I certainly have evolved my thinking as I've had a son who's now been in practice for the better part of 5 years, and working with chiropractors more locally, I've been impressed by what they can accomplish. Certainly for a couple of decades there was a lot of strife between spine surgeons and medical doctors and chiropractors, but what's your sense of how they can contribute to the well-being of our patients?
Well, this is the statistic. There are more patients are helped by chiropractor than spine surgeon. This is the fact. They do a tremendous job in any other medical problem. If you have the right treatment for the right patient, you help them. If not, you refer the patient to somebody who's specialized in that area. So what that means for a chiropractor, that statistically about 1/3 of people with spine problem, their first exposure, first contact is to chiropractor. And many of those problems can be dealt with by a chiropractor. They are well trained in variety of treatment for the spine. There are certain things that are beyond the scope of a chiropractor or a physical therapist or a regular orthopedic surgeon, but there are certain things that is beyond the regular treatment of a regular spine surgeon as well. When things really get difficult, that is actually where people like me come in play. When the situation becomes very difficult, very complex, like this patient I just saw in my clinic that has a severe scoliosis and tens of years, horrible pain. Imagine having 10 of 10 pain, worst pain you have had, not just for a moment, but for a year or 2 or 3. So coming back to chiropractor treatment, by them absorbing a big bulk of people who have problem and serving them, we are practically putting patients in different tiers that people who are helped by them, they should get their help. Once the problem grows beyond the reach of a chiropractor, that is where I, as a spine surgeon, come in.
Well, interesting. I'm glad. Honestly, I'm glad that you have that kind of approach to it. It's refreshing because so many see it as an antagonism, that they're doing things that are inappropriate. And I've learned to totally disagree with that. I think they do a marvelous work with what, as you say, within the scope of what they can cope with. So we now have this group of people that have developed problems, and they're going to come to our office, and we're going to do some investigation. So the investigation, most people have heard about it. They're going to have x-rays done. That's a pretty standard thing. And they're going to have very commonly a CAT scan done to look at the CAT scans are a little more effective way of looking at the bone structures, but often the nerves are involved, and to look at that really effectively, the new technology of an MRI. So we've got usually this combination of these three things of x-rays and CAT scanning and MRIing to give us a better sense of the deep structures and what we're up against. Is there any other investigations that people are likely going to have to go through before they end up in an operating room, or is that pretty typical?
Well, I go even a few steps back. We examine the patient. There's tremendous amount of information we get just watching a patient walk or seeing how they are reacting to certain provocation. Or we examine the muscle group. We see which muscle works okay and which muscles are not okay, or the distribution of the nerves or symptoms. If your thumb and index finger are numb, it's a different nerve than if your middle finger is numb. We get tremendous amount of information just by watching the patient, examining the patient, putting hand on, and these days I think we don't just jump to the imaging primarily. Imaging is what complements our exam or our working diagnosis or differential diagnosis as we call it. We have a pretty good idea what we are looking for. And I think that is as well the huge difference between when you get a report of the radiologist and you read it, that radiologists have not laid eye on the patient, has not examined the patient. So what he does, he describes every little things that is he sees. That's his job. They are doing it beautifully. But then you get a patient that comes to us and describe or reads things on the note and try to understand that. And my job as a clinician is to put those information in the context, in a clinical use, because I probably have some of those findings that are described for my patient. Now, is it relevant or not? Now, to what extent it is relevant, it's a correlation between the clinical symptoms and the imaging. And yes, you're right, there are multiple ways of getting the pictures. Regular X-ray, they are still widely in use, but these days, as a spine surgeon, I mostly use them for to show if the bone slides forward and backward. We bend the patient forward and backward and get those films to see if its bone is moving forward and backward. Obviously, if there's a huge pathology and really bad situation, often it's reasonable to use just the X-rays for that to see how much it's shifting. But barely we only rely on regular X-ray, at least not in my specialty. Then we have MRI that which literally shows us the nerves and the disc structure beautifully. And if there is a disc coming out, pushing on the nerve, that's a very good situation that you in MRI, you can see that the content of the disc is coming out, pushing on the nerve. But for some areas, MRI is not the best. Like for bone structure, for the joint structure, CAT scan shows beautifully the bone structure, especially if somebody had previous metal. Not only the metal is not visible on MRI, but as well it creates a shadow around itself. It obscures our view for other things. So if somebody had a previous surgery, CT is a very good picture. Now, there is a modification of this technique, CT technique, where we put a little contrast. We call that exam myelogram. By putting a little contrast inside of the spine, and people like me do that, or sometimes radiologists do that, adding some contrast to the spinal canal, to the what we call cerebrospinal fluid, we are able to get all the information of the MRI and CT in one. It's an invasive procedure, but it gives me, as a specialist, way more information than any of those exams alone.
So there's a variety of things that would potentially would be done. So it would be rare that these things would be done before they get to your office, but they might be something people would expect to see after they get to your office. So very briefly, we'll mention that the wonder of how this has changed in recovery times and in surgical times are things that I'm looking at, and just my jaw drops when I see how much different things are compared to where they were 20 years ago. So a very common procedure would be to fuse, say, two of the lower lumbar spine together because of a problem with either bad arthritis or maybe a totally worn out disc, or there might be compression on the nerve roots in the area. Now that, as an open operation that I was taught to do back in the mid-1980s, that was an operation that would probably take us, to do the proper fusion, maybe 3 hours. And we would have to take a chisel, literally a chisel and a hammer, and we would be breaking some of the marrow bone out of the lower part of the pelvis bones, and using that to use as a graft around the side wings of the lumbar bones. So a big operation, and these patients were horribly uncomfortable. So what can they expect now from you with that kind of procedure?
Yeah. Well, if you guys did that in a long time ago in 3 hours, you were on the top of your field. Because even now, in average for a one-level fusion is about 2.5 to 4 hours. As a matter of fact, Mayo just published, they gave a presentation in 2016 that if your BMI, body mass index, is below 35, the average time for the surgery is 3.5 hours. If your body mass index is above 35, the average surgery for a one level is 4 hours and 20 minutes. In that 4 hours and 20 minutes, we are cooking the tissue to stop the bleeding, we are destroying the surrounding tissue just to get where we need to go. And by us using a tube, we are literally within minutes, we are where we need to be, and all that cutting, cooking, destroying the tissue around the spine goes away. So literally, we do that surgery now, skin to skin, in 35 minutes. And those patients, last week, I did 7 of those surgeries and sent that patient from a surgery center home. I'm talking about very complex surgery. Now, I need to emphasize that still more than 85% of the surgeries in the United States are still performed open old-fashioned way. And maybe in our hospital here in Crookston, we got just used to it, that we do a surgery and patient go home next day. This is by no means what happens out there.
So you're saying that the typical case, 85% of the time, that same procedure done in other facilities would still take them 3.5 to 4 hours. The patients would be in hospital 3 to 4 days. But in Crookston, that operation is now condensed down to a 35-minute event, and some of them going home the same day, some of them going home the next day.
And they are, in the majority of the cases outside of this community, the surgeries are still performed the way you watched them in 1980s.
Yeah.
And on top of that, I think I cannot emphasize it enough, all that additional time you're spending there has practically adverse effect on patients' outcome. Literally, big studies show that every additional 30 minutes under just anesthesia, independent of what you do, adds 17% to the combined risk of the surgery. That's why we can do these big surgeries on 80-year-old people who have scoliosis, where other surgeons literally tell the patient truthfully, you will die of this surgery. You cannot have this surgery.
Yeah. And there's an interesting dilemma. I often send my patients to a website from the University of Connecticut, and with it they have a online chart that you can answer a number of questions, and it will allow you to get some sense of how many more years in life you can expect to have. And it's quite eye-opening for some people, and there's many people who are in their mid-80s who are actually quite healthy. And with the chart, I'm able to point out to them that probability says that they're going to likely live another 8 to 10 or 15 healthy years. And meanwhile, they've got this one problem, and they're debating about whether or not they're too old to have the surgery. And I'm going, well, do you really want to live with that problem for another decade? Because you're going to be around for that length of time. So this kind of less invasive surgery for the spine has now opened up a whole new avenue for some of these octogenarians and nonagenarians that before we never would have touched them surgically because they were too at high risk. But now that there's an opportunity to do things, and I'm seeing kind of something similar in my own shoulder operations where I can now operate on 90-year-olds that I would never have touched before because we can finish the operation in 45 minutes and send them home the next day. So this is moving us into the forefront in spine surgery. Now, we don't have a lot of time left in the discussion today, but I know that there is one area that's very near and dear to your heart of something new that you've developed that has now moved things along a little bit further down in the back. We all remember Bugs Bunny talking about his aching sacroiliac. So talk to us a bit about sacroiliac disease. Now, the sacrum is the center of the spine as it goes down. The iliums are the bones that we call our pelvis bones going off to the sides. And the sacroiliac joint, or the SI joint, is the joint between these two. Now, it doesn't, if you look at a skeleton, it doesn't look like there's much of a joint there, but there actually is a joint there that does have a little bit of motion. And that little bit of motion can produce problems. So tell us about that.
Well, actually, practically what we call this sacroiliac joint, we call it adjacent joint to the bottom of the spine. So practically, we know that if you have a spine problem, you are 35% more likely to have other spine problem because the same process that destroys one area affect the other area. Sacroiliac joint is just adjacent segment or the next level to the bottom of our spine. And the sad thing is that it's so completely neglected by spine community to a point that many of these patients are sent out, nothing is wrong with you, because we just don't look into that. Now, when we look into that and treat that, we can treat it better, faster, a day surgery, and we not only do that very good job of diagnosing it, and I'm one of the surgeons who have most of the number in the state of Minnesota, but we have to actually develop the system that enable us to do that surgery literally in 15 minutes, skin to skin, and that can really bring a lot of improvement for the patient. I want to emphasize as well that we should understand where we are here. There is a web page that all the hospitals in the state of Minnesota, they put their numbers down. How long do they keep their patient, or how long do they have to keep the patient in the hospital before the patient is ready to go home? That number for most of the hospital, including the university, is about 4.2. Some hospital is 6.2 in days in the hospital. In Crookston, that number is 1.6.
1.6.
We have the lowest acuity for those patients that need to stay in the hospital before they are ready to go home, because we do this kind of minimal invasive procedures that put the people on their feet within hours. And talking about the COVID, the hospital beds, and so on and so forth, this is a tremendous kind of effect that we produce, be able to treat the patient, and they're good enough to go home in 1/3 to practically 1/2 of the time that even big hospitals in the city are able to bring the patient to the point that they're ready to go home.
So the sacroiliac, we'll just go back to that again. So it's amazing. We're in little old Crookston, same apples to apple comparison of the types of surgery and the same complexity of surgery. Patients are going home in roughly 1/3 of the time that they are in the other facilities in this state, and very much the same in the rest of the country.
No, it's not the same level of the complexity, because once those surgeons in the city, they say they cannot do it, that is when the patient finds us and they come to us.
So these are even more complex patients.
They are, definitely are.
Than what we're dealing with. So that's even more remarkable that they're going home in, like you say, 1/3 of the time. So in the sacroiliac joint, you say you developed this technique, and that the procedure can be dealt with in 15 minutes, where we're effectively fusing this joint so it's not moving this little bit of micro motion to help with the pain. And I can speak back to when I was training, that was a 4 or 5 hour operation to try to fuse the sacroiliac joint. And because there are some nerves that are very close to the very front of the spine, it was a very dangerous operation as well, trying to put the instrumentation in, and the risk of producing permanent nerve damage in the leg was quite substantial. So it wasn't something that people relished doing as far as a procedure. So it was a long, difficult operation with a high risk profile. And now you've managed to reduce that very common problem to a much simpler solution when surgery is needed, to say a 15-minute event. So imagine people going from 4 hours of surgery to 15 minutes and being able to go home the same day. It's the transition that's taking place here in spine surgery is literally jaw-dropping how much we're changing things.
And that is, I would say, has been as well for me tremendous to watch how far we have come by using these technologies that is truly available. We just put these technologies like a piece of Lego together and enable to create a service that is really second to none. I can truly say that our service in musculoskeletal here is second to none, and that is our goal, to develop this community to a destination where other people from other places come to get their care. Just last time I was here, patients have been driving from Nebraska and lots of 500 miles to come to Crookston to get their care. We can just develop more on that. This is a lot is to come.
Yeah, this is it's amazing how it's transitioning and changing and moving forward, and there's nothing but good things coming forward. Dr. Abbasi, it's been a pleasure having you back on the air again. You know that I'm going to get you back here again sometime in the future to talk more about how this is all proceeding. But we're certainly in a major transition here in Crookston, where we're doing much more of this kind of procedure. And as you said, patients coming from other states now to come to Crookston to have their spine surgeries done, and being able to go home within a day or two, where they're home in their own bed faster than it would be if they stayed in their own state. So they're very happy.
It's always my pleasure. One of my most important duties is to teach the community and the public. So if you have more questions, just go to IS Life, where we talk about these issues and educate our patient.
So it's ISLife,
IS Life.
LIFE.com.
IS Life, actually, it's you can go to islife.org.
.org. Okay, all right.
That you can get more information.
All right. ISLife, ISLIFE.org. And you can look that up online. There's a lot of more information of what all the different things that can be done. Thanks again for making the effort to come in. I appreciate it.
My pleasure.